of the provisions, some of the provisions in the 2024 final physician fee schedule. This is not a comprehensive overview. There's a lot of stuff that we won't talk about. We're trying to stick to some of the more relevant highlights. When we get to the end, if there's anything that I did not cover that you have questions on, please feel free to ask, or anything that I do talk about. Also very happy to answer any questions you have on anything. Next slide, please, Allison. So the things that we're going to go over today are the conversion factor, which of course affects payment in 2024, and then what that looks like for the hematology oncology specialty as well as radiation oncology. Some changes that CMS has made to coding for evaluation and management services. Additional coding changes that CMS has finalized to address health equity, telehealth, dental coverage, and then a few other policy updates that are relevant to the cancer care community. And then finally, to end, we will talk about some of the things that CMS has finalized in the quality payment program that will affect payments in 2024. And then at the end, there will be plenty of time for questions. Next slide. All right, so to get us started, the conversion factor. So the 2024 conversion factor will be $32.7442. This is a 3.37% reduction from the 2023 conversion factor. This reduction in the conversion factor is due to three things. The first one is the budget neutrality adjustment. That is an adjustment that is made within the fee schedule that keeps, essentially what it does is it keeps the amount of money the same, but it redistributes the dollars across the different services based on the expected utilization. So there's the budget neutrality adjustment. There is a statutory update of 0%. So Congress has said that for 2024, there is no automatic update to the conversion factor. We stay where we are. And then the last thing is an addition to the fee schedule that stems back from the first E&M changes back in the 2020-2021 timeframe. So you may recall that back in 2021, CMS, they added an additional 3.75% into the fee schedule. And this was for two primary reasons. Partially, it was to offset all of the redistribution of money due to the changes for the office and outpatient E&M. And then also because the pandemic was going on and they were really trying to make sure that practices had the resources they needed during the pandemic. So that addition into the fee schedule has been slowly decreasing over the last 4 years. So in 2021, they added 3.75%. In 2022, it was 3%, and so on. So now we're down at 2.5% in 2023, but next year it's going down to a 1.25%. So that's the final thing that is driving that reduction in the conversion factor. We're going to talk really quickly about the budget neutrality adjustment and why that budget neutrality adjustment is going down, and by going down so much. The next slide, please, Rachel. So the bulk of the budget neutrality adjustment has to do with the new code for, it's an add-on code for evaluation and management services for complex patients. This is G2211. This is a code that was finalized in the 2021 final rule, along with all those other office and outpatient E&M changes. When CMS originally proposed this code, they assumed that it would have a 90% utilization. That means that they expected everyone who was billing E&Ms, an office or an outpatient E&M, to add on this code 90% of the time, which is fairly high. That's actually quite high. If that were to be the case, that would cause $3.3 billion in the system to have to be redistributed, which was going to change the RVUs and the reimbursement for services across the board in a negative manner. So that code alone would have caused a 3% cut to the conversion factor. So because this is going on during the pandemic and all those other changes to E&M, what happened was Congress delayed the implementation of this code to prevent the conversion factor from going down so much. So now let's go back to 2024. You can go to the next slide, Rachel. So now we're back in 2024 and Congress has said, okay, yep, you can go ahead and reinstate that code. And so CMS proposed to reinstate it and they will. So they're moving forward with G2211. They have revised the utilization assumption from 90% to 38%, which doesn't cause as much of a shift in the fee schedule, but it still does cause a shift. So if you look at that budget neutrality adjustment, that one that's highlighted in yellow at the bottom of your screen, 90% of that budget neutrality adjustment, so 90% of that part that is causing the decrease in the conversion factor is due to this one code. So it's just something to note that is why that's why the conversion factor is going down, is because of this one code, and then also because of the other two things that we talked about. I think the point here that I'm trying to make is really just that it is the budget neutrality adjustment is a big deal, and even one code can have significant impacts across the fee schedule. Next slide. Okay, so let's look at what the specialty impact is. I'll get less technical now. That was probably the most technical and hard part to understand, especially at the end of a workday. So every year in the fee schedule, CMS puts out what they estimate to be the impact on different specialties. So CMS estimates that the hematology oncology specialty as a whole will see about a 2% increase in payments in 2024. At the same time, they are estimating that radiation oncology as a whole will see a negative 2%. These are just estimates and they are across the board. It's not an individual look at what your reimbursement will be in 2024, but it's just meant to give a general idea. So at ASCO, we do our own analysis also to get a better look at what we can expect reimbursement to look like in the coming year. So there's a few things that CMS does not take into account when they release those impact tables. The first one would be that additional funding that Congress has allotted to the fee schedule, that 1.25%, and the fact that it is decreasing next year. So this year we're at 2.5%. Next year it goes down to 1.25%. So that reduction is not included in that impact table. There's some other factors that have to do with the geographic adjustments. There are certain floors and those have to get addressed by Congress, and that has not yet been done. So unless something happens, those are not included in that specialty impact table that CMS releases, but they are in our impact table. And then finally, just more specific RVU changes for services that oncologists build. So we estimate, again, as a whole, the hematology oncology specialty will see about a 0.2% decrease in payments in 24, and radiation oncology about 3.5% reduction in 24. Like I said, this is just an estimate. This is just a really high overview. Your actual reimbursement will vary based on where in the country you practice, the patients that you see, where you see them, and the mix of services that you bill. So there's a lot of things that will affect payment. This is just a high-level overview. Next slide. Okay, so let's talk about evaluation and management. We'll go back to that G2211 code for complexity. So this is a code that CMS has finalized. It is only billable by Medicare. Private payers will not accept this code. This is a Medicare only code. And it's for primary care or ongoing medical care related to a single serious or complex condition for a new or established patient. G2211 can be reported in addition to a primary E&M service, so 99202 through 99215, any office or outpatient E&M. And it's meant to capture a continuing relationship between a physician and the patient. You cannot bill this code with a modifier 25. So if you are doing drug admin on the same day as an E&M and reporting that 25 modifier, you will not be able to report the add-on code for complexity. And then the reimbursement for the G2211 by itself is $16.04. This is not the geographically adjusted rate, but just the published rate. And that would be on top of whichever E&M service you are reporting. So that code is up and running, or will be, in January 1st of 2024. Next slide, please. Okay, another change to E&M. So split shared visits. These are visits that occur in a facility setting in which both a physician and a non-physician practitioner are seeing the same patient. This has been something that CMS has, for the last few years, they have been trying to change the way that billing for these services is done by changing the definition of substantive portion of the visit. So according to CPT guidelines, those who provide the substantive portion will bill the service, whether that's the physician or the non-physician practitioner. So CMS has been proposing to base that definition on time alone. So whoever spends the most time with the patient would be the one to bill the service. Stakeholders, including ASCO, we've been pushing back very hard on this. We just don't think that it is appropriate or feasible for physicians and non-physician practitioners to walk around with a stopwatch and time how long they were in with the patient and how long they weren't, and then to try to add that up at the end of the day and make sense of it. We're like, no, that's not how team-based care works. And so we push back really firmly on that. And CMS has, in fact, they've no longer delayed it, but now they've finalized that physicians and non-physician practitioners can use time or medical decision-making. So no more running around with a stopwatch. You don't have to worry about that. That will not happen, at least for the time being. That the substantive portion of a split shared visit is determined by time or medical decision-making. And that is in alignment with CPT guidelines. This is seemingly permanent for now. I mean, they do say that they could address this in future rulemaking, but for now we're set, and hopefully we won't see this again in next year's rule. Next slide. Okay, CMS, the agency, is doing a lot to promote health equity and addressing health disparities. This is agency-wide, and all their programs, they're really putting an effort on how to improve health equity. So in this year's proposed rule, CMS has proposed and now finalized a set of 3 different codes to address different health equity needs. The first one is a social determinants of health risk assessment. So CMS has finalized that they will reimburse for those times when you administer a standardized evidence-based risk assessment. This is an assessment that would take about 5 to 15 minutes, and it would only be reimbursable every 6 months. So you couldn't do it every time you see the patient, but it would be every 6 months you could bill for this service. You need to use a standardized or evidence-based tool. Again, it would be 5 to 15 minutes. CMS does encourage people to report the Z codes. These are the ICD-10 codes that identify social determinants of health needs. They're not requiring this, but they are strongly encouraging it. And then the other thing to note is that cost sharing will apply. So if you do go ahead and bill this code, unless you have a patient who is receiving the risk assessment during an annual wellness visit, if it's just during a standard E&M, then they would have to do cost sharing. They would be responsible for their cost sharing part on this code. And this code is also going to be added to the Medicare telehealth services list so that you can do a risk assessment through audiovisual technology. The intent of this code is not to screen every single individual, but it is meant to assess someone with suspected or known social determinant of health related needs. And the reimbursement for this code will be $18.67. Just going forward, every time I talk about reimbursement, it is not geographically adjusted. It is just the standard base rate. Okay, next slide, please. So in addition to the social determinants of health risk assessment code, CMS is also finalizing a set of 2 codes that will, once a physician identifies some needs for patients, then billing these codes would give them reimbursement for connecting those patients to community health resources. The focus of these is addressing those social determinants of health needs that interfere with or present a barrier to diagnosis or treatment of the patient's problems. An initiating visit has to happen first, and then you could bill those codes to set them up with a community-based resource. So there's several things that are included in this code, things that the community health worker can perform. So they would communicate with all service providers regarding the patient's psychosocial requirements and then preferences and desired outcomes. They would help them build self-advocacy skills and then educate the patient on how to participate in their own medical decision-making. They help coordinate care, both services and transitions between the community and then the healthcare providers themselves. They facilitate access to community-based social services. They provide social and emotional support to cope with whatever need they have. And then they also establish a plan through a person-centered assessment. So the first code is G0019. This is for 60 minutes. And then G0022 is for each additional 30 minutes. Next slide, please. So the services can be performed by a certified or trained auxiliary personnel under the direction of a physician or another practitioner to address the social determinants of health related needs. So the physician would actually bill the service, and then the patient works with the community health worker. Like I said, the E&M or an annual wellness visit is needed to initiate the community health integration services. A physician needs to acquire verbal or written consent during that time, and that does need to be documented in the medical record. And again, patient cost sharing does apply to these services as well. A patient cannot use community health integration services when they have a home health plan of care. And then reimbursement for these codes for the first 60 minutes is $78.92. And then for the following 30 minutes, it is $49.45. So that first code, G0019, would be a one-time billing in a month. And then the G0022, there's no frequency limit. So you can bill that one as often and frequently as you need to make sure that the patient is getting the resources and the help that they need. Next slide. And then the final set of codes that CMS has finalized is for principal illness navigation. So these are services, again, the physician would bill, and then it would be a certified or trained personnel working under the direction of the physician that would actually perform the navigation services. The activities that are included in these are the same as those in the community health integration, with the exception of one. There is, the second bullet down says identifying or referring patient and the caregiver or family, if it's necessary, to the appropriate supportive services. So that one is in addition to all of those other elements that are included in the community health integration. Let's see. Give me 1 second here. Sorry, I'm getting. We can go to the next slide, please, Rachel. So again, this actual navigation services would be performed by certified or trained personnel under the direction of the physician. This is to address a serious or a high-risk condition that is expected to last 3 months or longer. If it's something that will be resolved quickly, then CMS will not reimburse for this service. And then again, like the community health integration, you have to do an E&M or an annual wellness visit to initiate an principal illness navigation services, and you also have to acquire that verbal or written consent, and that needs to be captured annually. Social determinants of health needs do not necessarily, they won't necessarily be apparent, or not that they won't be apparent, they won't, a patient may not have those needs, and they would still be able to bill principal illness navigation. The point of this is really to make sure that those who have those serious illnesses such as cancer, that you can navigate them and make sure that they get the appropriate services that they need. They do not necessarily have an outside social issue. This can be provided more than once per month per practitioner, and then the reimbursement is $78.92 for the first 60 minutes, and then the following 50 minutes is $49.45. Okay, I think that's it on that. All right, let's go to telehealth. We'll switch gears a little bit. So most of what's happening in the fee schedule for this year is the continuing of the telehealth flexibilities that were in place during the public health emergency. So Congress has passed the Consolidated Appropriations Act of 2023. It really extends those flexibilities through the end of 2024, and then CMS is just finalizing through regulation what flexibilities are still in place. So the first one is the originating site and geographic restrictions, meaning that a patient can receive telehealth in their home. They do not have to travel to a distant site to receive telehealth. And it doesn't matter where in the country you are located, anyone, anywhere can use telehealth. You don't have to live in certain designated rural areas. If a beneficiary or if a patient doesn't have access to audio and visual technology, CMS will continue to reimburse audio-only services. So those services that are on the Medicare telehealth services list, those will be reimbursable as an audio-only service through the end of 2024. During the pandemic, CMS has added on a fair amount of codes on a temporary basis, and those will continue to be reimbursed and available through telehealth through the end of 2024, as well as additional clinician types. These are occupational therapists, speech language pathologists, and audiologists. They will also be able to bill telehealth. And then finally is the higher non-facility payment rate. So during the pandemic, CMS was reimbursing telehealth as if the services were happening in the office and not through telehealth. So they will continue to reimburse at that higher non-facility payment rate through the end of 2024. Next slide, please. There is a few coding changes though that accompany that non-facility payment rate. So for 2024, beginning on January 1st, to receive the higher non-facility payment rate, you need to bill a place of service 10, which means that the telehealth patient is at home, and then you would receive the non-facility rate, which would be higher. If the patient is not at home at the facility, then you would bill the place of service for the telehealth patient. This does replace the I think it's modifier 95, which is currently what's being used. So just to know, there's some billing changes or coding changes along with that payment rate. The next thing is the home address. So CMS has suspended plans to require physicians who provide telehealth at home to report their home address on Medicare enrollment forms. They wanted, beginning like now, they wanted physicians who do telehealth at home to use their home address on their Medicare enrollment forms. Fortunately, they have delayed this policy, and you do not need to report your home address through 2024, though they do state that they will address this in future rulemaking. So right now through 24, and then we'll have to see what happens after that. And then the last thing, just as an FYI, really, Medicare is changing the way that their list is structured, and they have a permanent list of telehealth services and a provisional list. That provisional list is so that CMS can collect data, see how they're being used, make sure there's evidence to back up having those services on the list. That's more of just of an FYI. Let's see, next slide, please. So dental coverage. This has been something that's been going on for a couple of years, but CMS has finalized its proposal to allow payment under Part A and Part B for dental exams and other dental services that are performed before and during chemotherapy, CAR T-cell therapy, and then anti-resorptive or anti-angiogenic drug therapy, as well as for patients who are being treated for head and neck cancer. If they have head and neck cancer, then you can also, they can bill Medicare for dental coverage. This is something we had asked CMS to do, I forget if it was last year or the year before, but we're quite pleased that they are recognizing the fact that individuals who are on chemotherapy or receiving CAR T or that have those bone modifying agents really need to have proper dental care in order to have better outcomes, and that those two are really linked. You know, the medical procedures or not procedures, but the treatment for the chemo or treatment for the cancer along with their oral health care. Next slide. All right, just a quick few other policy updates. CMS finalized its proposal to maintain the in-home payment for a COVID vaccine administration. This is under Part B. So if a patient receives a COVID-19 vaccine at home, there is an additional payment for the provider. And they have extended this also to pneumococcal influenza Hep B vaccines when they're provided in the home. If you go into somebody's house and give them 3 vaccines, you can only get that additional payment once. You don't receive it each time for each vaccine that you have given. It's you just bill it once, regardless of the number of vaccines the patient is receiving. CMS finalized its policy to rescind the regulations around the appropriate use criteria program. they're going to still encourage individuals to use some sort of clinical decision support, but they are officially getting rid of the AUC program. This is something that we will continue to monitor, because it's possible that something else could pop up in its place a few years down the road. It would have to go through rulemaking. We'll learn about it, but just something that we'll keep an eye on. But for now, the AUC program is no longer. And then finally, CMS also finalized its proposal to delay penalties for those that do not comply with electronic prescribing of controlled substances. The agency will continue to send, I think, letters just notifying you that you are not in compliance. And then they will also offer educational opportunities and then try to offer support so that you do become compliant. They will continue to monitor this, and will probably address it in future rulemaking also. But through 2024, again, it's just a notice of non-compliance. There is no other penalty. Okay, and the last little bit, next slide, please, Rachel. We'll just touch a few things on the quality payment program as they do affect reimbursement in the coming years. So in the proposed rule, CMS proposed to increase the MIPS threshold from 75 to 82. When they did this, they estimated that if they were to move the threshold to 82%, or sorry, to 82, that about 54% of clinicians would receive a penalty under MIPS for the 2024 performance year. They have decided not to finalize this threshold of 82, and they're keeping it at 75, which does reduce the estimated number of clinicians that would receive a penalty. CMS estimates that it would be about 22%. So 75 is much better than 82. We were happy that they did not move forward with that proposal and that they're keeping the MIPS performance threshold at 75. So if you hit that 75, you have a neutral payment adjustment. If it's higher, you'll have a positive payment adjustment. And if it's below 75, you would have a negative payment adjustment. The QP determination. So this is for a qualifying participant in an advanced APM. So we had concerns with making, so CMS proposed to make the QP determinations at the individual level instead of at the APM entity level. We had concerns with this because it would make it very difficult for oncologists to meet those QP thresholds on their own. And so we pushed back and said, you know, you need to keep doing this at the APM entity level. CMS agreed, and they will continue to make those determinations at the entity level and not the individual level. The APM thresholds these are set in statute, so there's nothing that CMS can do to change these. The payment threshold is 75%, so 75% of your payments must be coming through that APM, and then or your 50% of your patients need to be enrolled in an advanced APM for you to meet that threshold. Let's see, and then finally, the APM incentive payment. So after the 2023 performance year, which is this year, the APM incentive payment will end. There is some discussion in Congress right now about potentially addressing this for 2024, but nothing has been decided yet. So for next year, for the 2024 performance years, the 26 payment year, there is no APM incentive payment. Let's see, and I think that's all I have on the quality payment program. You can go to the next slide, Rachel. Yep, and I'm happy to take any questions that anyone has. I know it's the end of the day, and if you don't have any now, you can always email us too.
I don't see any in the chat right now. But as Gina said, you could email us at practice@asco.org, and one member of ASCO staff will get back to you. Oh, wait, we have one. Someone asked, who can bill the navigation services?
Those would be billed by a physician, or Rachel, you can correct me if I'm wrong, a non-physician practitioner, someone who has the ability to bill Medicare, and that it would be done under the supervision of the physician.
That's correct. So both the community health integration services as well as principal illness navigation services, those are both billed under a physician or qualified healthcare professional, someone who is able to independently bill Medicare. And it is under general supervision of that physician or qualified healthcare professional in performance of those services.
Don't see any other questions in the chat right now.
Just a point of clarification too. I mean, I know I mentioned it with the G2211, but the community health integration, the social determinants of health risk assessment, and the PIN, the navigation, those are all Medicare only codes. Private payers would not reimburse those. Those are just Medicare codes, and cost sharing will apply for the beneficiary.
Okay, well, we'd like to thank everyone for joining us here today. As we noted before, this webinar is being recorded and will be posted online. And don't forget to go to ASCO Practice Central to view our coding, billing, and reimbursement resources. And feel free to email us at practice@asco.org. Thank you very much and have a good night.